I wish you a happy new year, and at the same time, I wish that this year brings hope, optimism, and positivity in our lives. The topic of today's webinar is current concept in the management of fibrous dysplasia. Fibrous dysplasia is really a challenging problem. In spite of a lot of advances in the medical research, probably this is one condition where we as a pediatric orthopedic surgeon feels that probably we have a limitation in our knowledge and limitations in our techniques which we are offering to our patient. We are really fortunate that we have a wonderful expert panelist with us. We have Professor Ippolito from Italy. We have Professor Fritz Hepti from Switzerland. We have Fergal Monsell from UK. So we have European experts on the topic. And in addition to that, we have Professor Premal Nayak and Professor Thomas Palokaran from India. So I'm sure that these experts are going to have a lot of wisdom, and they are going to share their experience with us. Let me give you a brief introduction about our panelist. The Professor Ernesto Ippolito is Emeritus Professor at University of Tor Vergata. That's a pediatric university hospital of Rome. He is very famous for his work with Dr. Ponseti, and he did a very extensive molecular research on the muscles in the clubfoot. He was a president of Italian Society of Pediatric Orthopedics, also a president of European Pediatric Orthopedic Society, and he's reviewer of very famous journal like JBJS, Clinical Orthopedic, Journal of Pediatric Orthopedic A and B, and JCO. The second expert with us is Professor Fritz Hepti. He was for 22 years the Chief of Pediatric Orthopedics at University Children's Hospital at Bot Basel. Since 2010, he is a senior consultant at the same hospital. He is one of the editor-in-chief of Journal of Children's Orthopedic. He is also a director of International Hip Dysplasia Institute, and he has a lot of interest in hips, tumors, and congenital deformities. He is also famous for his major contribution in the form of a textbook, which is Pediatric Orthopedics in Practice, which has a lot of practical wisdom about management of pediatric orthopedic conditions. Then we have a third expert on the panel is the Fergal Monsell. He is from Royal Hospital for Children in Bristol. He is a senior lecturer at the University of Bristol and director of A1 Center for Musculoskeletal Education. His main interest is pediatric infections and deformity correction. He is a good friend of POSI because he has attended many of our annual conference at Ahmedabad at Vellore. So Fergal is a good friend of POSI. He is also going to speak at the end on the position statement which was recently published in this Orphanet Journal of Rare Disease. That's about the protocol of management of this difficult condition. Dr. Premal Nayak is a honorary consultant at Municipal Medical College in Ahmedabad. His interests are pediatric trauma, deformity correction, hip infection. In addition to orthopedics, he is also interested in singing and traveling across the world. And the Thomas is the professor and head of the pediatric orthopedic service at Christian Medical College, Vellore. And he has also a great interest in tumor and fibrous dysplasia. So with this short introduction about our faculty, before we move on to the webinar, I would like to remind you that if you have not registered for our virtual POSICon, please register by visiting the www.posi.in. Regarding the next webinar, on the 24th of February, we have a webinar on osteochondral lesion, and we have Professor Milinder Cockers from Harvard Medical College with us on the same topic, and we have another few experts who are going to share their knowledge on this condition. So with this, now I hand over to Professor. Professor lecture is basically a recorded lecture, but we will stop in between at the time of the questions, and then we will have a faculty interaction with us. So with that, I'm going to share the lecture.
Fibrous dysplasia of bone in children, pathophysiology, clinical aspects, treatment, and long-term prognosis. Fibrous dysplasia of bone is a genetic disease caused by a mutation leading to an increased synthesis of the protein G that stimulate mitosis of the preosteoblasts that assume the phenotype of fibroblast-like cells. Only few preosteoblasts reach a more mature stage, forming thin and irregular bone trabeculae, assuming a Chinese writing pattern, with scanty mineralization like in osteomalacia, and structural anomalies leading to bone fragility. Dilated vascular channels are present in some tissue areas, bound to bleed if injured. Since the mutation is post-zygotic, the result is a mosaic state in which normal and dysplastic bone coexist. Fibrous dysplasia of bone may be classified in monostotic form, polyostotic form, McCune-Albright syndrome, Mazabro syndrome. The most frequent clinical manifestations of the disease are pain, swelling, deformity, limp, and fracture. Fractures are rare in monostotic fibrous dysplasia, but frequent in polyostotic fibrodysplasia, McCune-Albright syndrome. And they are very frequent in McCune-Albright syndrome patients with phosphaturic factor. LIT has shown that the fracture peak in those patients is between 6 and 10 years of age. Radiology is the first choice imaging for fibrous dysplasia diagnosis. CT scan gives a better definition of FD lesions, but it is best indicated in craniofacial and ribs localizations. MRI gives an intermediate to low signal intensity in T1 and an intermediate to high signal in T2. It is useful to identify FD lesion limit within a bone, but not very useful for differential diagnosis of monostotic fibrous dysplasia. Bone scan usually shows an increased uptake, and it is very useful to evaluate skeletal spreading in polyostotic fibrous dysplasia. PET-CT scan has its main indication when a malignant transformation of FD is suspected. Monostotic form accounts for 70–80% of all FD cases. It usually has a delayed clinical presentation. It runs frequently asymptomatic, and it includes localized and diffuse forms according to the extent of the lesion within the affected bone. When symptomatic, it becomes clinically manifest by pain, swelling, bone deformity, and fracture. The most frequent localizations are femur, tibia, humerus, and ribs. And here you can see the list of the most common differential diagnoses of monostotic forms. We believe that bone biopsy is indicated in these cases more than imaging screening to make a quick and correct diagnosis. The treatment of choice in symptomatic monostotic fibrous dysplasia is curettage and bone grafting associated either with internal fixation or with plaster cast according to its localization. Wide excision, bone grafting, and internal fixation may be indicated in particular cases, like in this historical case of our collection, fixed by a dual fibular autograft plus Anders nailing. And now question case 1. AP radiographic view of the right lower leg of a 12-year-old boy with worsening right ankle pain started 2 months earlier. No local swelling, redness, fever, and normal blood tests with tenderness on the lateral aspect of the lower leg. What is your differential diagnosis? Would further imaging, in your opinion, be helpful for a differential diagnosis? Would it be appropriate to indicate bone biopsy after this radiograph? What kind of bone biopsy do you advise? Would it be possible to look for FD mutation on the paraffin-embedded tissue?
Okay, so now we have the opinion of our expert panelist. We would like to start with Professor Hepti. Sir, what do you think about the differential diagnosis of this X-ray? Sir, you are muted.
Yes, can you hear me?
Yes, please.
It's not really very typical for a fibrous dysplasia. It could be a fibrous dysplasia, but it's not a typical picture. And I really think we should do an MRI and then a biopsy.
Okay, right. And biopsy, which type of biopsy will you prefer?
Well, with a trocar.
Trocar, okay. And if you have a genetic study available, I'm sure that it's available in Switzerland. Will
Yes.
you go for it, or you will not consider genetic study in this case?
Well, if this is the only lesion, I would wait until I know what it is.
Okay. Right. Yes, Thomas, what do you think about this case? So what are your views on this?
Yeah, I think it's more a cortical-based fibro-osseous lesion. It looks, to me, it looks like a non-ossifying fibroma or a fibrous cortical defect. It looks a bit it looks innocuous. So I'm not in favor of a biopsy. I'll probably follow it up with X-rays after some time.
Okay, Fergal, would you like to say something different? I'm sure that your opinion will be different. So what do you think about? Do you agree with Professor Hefty and Professor Thomas?
I've just literally come in. Are we live at the moment?
Yes, yes.
Yes, yeah, we are live.
Beg your pardon. So,
Yes.
well, I'd need some further. I mean, first of all, I'd need just, apart from the basic workup, I'd need some further imaging, and because it's relatively straightforward for us to get, we get an MRI scan reasonably routinely on that, I think.
Okay.
He's
Right. And what about the biopsy? Will you go for biopsy after MRI, or you will not go for biopsy?
It depends on the MRI scan. I mean, with biopsy, if this is an isolated thing, then I think it's not character. It doesn't have hallmark features of anything. It's you know, there is a broad differential, and I would want to have some confirmation of that. So because it's an accessible site, a relatively low morbidity, but depending on, you know, the MRI workup and other workups, that then I would be, you know, I'd have a relatively low threshold for doing that.
Okay, right. We will have the opinion of Dr. Premal in the next question. So let's move on. Yeah.
The histopathologic diagnosis was fibrous dysplasia. A bone scan excluded polyostotic fibrodysplasia. Curettage and bone grafting was proposed, but the family wanted to have another opinion, and the boy was lost to follow-up. He came back 18 months later with a huge blown-up ground glass lesion, sparing both distal physis and epiphysis. His lower leg was swollen and anterolaterally bowed. What treatment do you advise at this point?
Okay, now we will start with Premal. Premal, what do you think about this situation? This is a very common situation in Indian scenario. Like you suggest something to the patient and then they don't accept your advice and they go to someone else and they come to us after a few months. The same situation has happened. So now what will be your take on this?
I think the best thing here would be to correct deformity and stabilize it with intramedullary implant, because it has been shown that bone grafting, whatever type you use in pediatric cases, is most likely to get absorbed. So best thing would be to correct the deformity and maintain it with either growing rods or maybe endosnail as shown in previous case.
Okay, so you would suggest to correct the deformity to go for the internal fixation in the form of growing rod or the Enders nailing. Yes, Professor Hefty, what do you suggest for this case?
Yes, absolutely. There is a biomechanical problem. So we have to straighten that leg and to fix it internally with some intramedullary device, whatever it is.
Okay, and what about the lesion? Will you leave it like this or will you consider to do something for the lesion?
No, I think I would leave it like this.
Okay. Yes, Fergal, do you agree with the two opinion or you have something else to say?
No, I completely agree. Although it's technically slightly difficult, you need some intramedullary stabilization to get the mechanics right. If you do that, sometimes you'll see some improvement in bone stock, but not because the fibrous dysplasia is under control, but because the normal bone's under control. And I think if you do adjuncts like you try and curate it out and biopsy and graft it, that's just not going to work, because in fibrous dysplasia, you know, pretty much agreement in the literature that any graft you put in will just result in reabsorption and coming back. So I think it's not, you know, I would absolutely agree, but would be, you know, strongly stressing about not grafting.
Okay, and Thomas, do you agree with the opinion or you have something else to say?
Yeah, so we will go ahead and do a curettage, probably stabilize it with a rush nail, a solid intramedullary nail. Like in osteogenesis imperfecta, we sometimes start from below for the distal third lesions. And because we don't have rotational control, we may have to put a plaster, a bony plaster. after doing.
Okay, so now we have, yeah, so now, sorry, so now we have a difference of opinion, like 3 versus 1. Like the 3 experts, they say that they will not do anything to the lesion, and the Thomas is in favor of curating the lesion. So let's have the opinion of Professor. Let's see what was done to the case.
We performed an intralesional corrective osteotomy stabilized with the antegrade introduction of 2 ender nails to spare the still active physis. And 3 years later, further cystic expansion with partial recurrence of the deformity is evident, as well as 5 centimeters of leg length discrepancy. However, the upper part of the lesion showed increased mineralization. Lower limbs were fully grown. What treatment now?
Okay, so again, we have a lot of questions. So all of you agree with what was done, or do you think that something else needs to be done in this case? Yes, Professor Hefty, what do you think? Do you agree with the treatment which was carried out in this patient?
Yes, I do.
Okay, Fergal. Okay,
Agree now.
Yeah, okay. So now coming to the next question, what more needs to be done now? What next? Yes, Fergal, let's start with you. What do you think? How will you manage this further?
Well, how old are they now? They're skeletally mature, so it's unlikely to change very much. And so you're dealing with the consequences of a 5 centimeter leg length discrepancy, which the solutions are many and varied. For 5 centimeters with what looks like reasonably good bone proximal to the lesion, you can probably make a case for doing a conventional lengthening above the lesion, ignoring it. You may want to stabilize beneath it, but your correction would be a proximal corticotomy with a fix. I personally, I would do it with a fixator. I don't think a lengthening nail would be either easy or appropriate for this. I would do a 3-ring system, stabilizing top and bottom with a lengthening at the top. Another thing, I can't see what's above the photograph, but I assume that that's relatively normal and that there's a reasonably good length there.
Okay, then there is a question from Dr. Premal, like, will you add any medical treatment to this, the surgical treatment? Yes, what will you add?
Well, the bisphosphonates have got a place, but usually for bone pain. And in patients that you use it for bone pain, you sometimes see an improvement in bone stock. So the pharmacology would be, provided the biochemistry is okay, would be more for managing any local symptoms, but it's certainly, it's something to consider.
Okay, and just one offshoot of the question, if you are going to go for a lengthening, will you give bisphosphonate at that stage, or will you withhold the bisphosphonate for some period?
Personally, I would be using bisphosphonates for local treatment of symptoms at the lesion, and provided that the bone is radiologically normal proximal to it, I wouldn't be taking any other particular precautions.
Okay, but
I don't use any pharmacological adjuncts when I'm lengthening anyway.
Okay, right. Yeah, Professor Hefty, would you like to say something or add on to the...
I don't think that bisphosphonates are a very good idea before doing a surgical treatment. You can do that afterwards or long time before, but the healing is impeded by the bisphosphonates, so I wouldn't do that.
Okay, right. Thomas, what is your take on that? Will you consider for bisphosphonate along with the lengthening, or you will try to avoid that when the lengthening is, you are contemplating lengthening?
No, bisphosphonates retard healing. So we will use bisphosphonates only after 6 weeks after the osteotomy has healed. So we won't use bisphosphonates when there's a fresh osteotomy or a deformity correction.
Yeah, Fergal, I'm coming to that. Premal, will you like to add on to this, or you agree with what Professor Hefty and Thomas mentioned or suggested.
So Dhirendra, I think the best thing will be to ask patient, does he really want anything? Because I think we have to keep the patient in the center, because the lengthening itself is not going to be an easy thing in this child. So I think I'll have full length discussion with the pros and cons of lengthening, and then only I will do something. Otherwise, I think we can just
Okay,
much
right.
problem, because it does not progress after skeletal maturity, most of the lesions, and no new ones wouldn't come after that age.
Right. Yes, Fargal, you would like to add something. You were saying that.
I just wanted to be clear that I wasn't suggesting treating anything but bone pain with bisphosphonates.
Okay.
I wasn't suggesting that should be part of a reconstruction. It's because you asked me about pharmacology. It's specifically for bone pain. But I'd ask Prema as well. Of course, you discuss with the patient, and of course it would be 5 centimeter difference. You don't have to treat. But do you see any particular differences in this lengthening than lengthening with other pathology if the bone proximally is normal?
Okay, so basically the question is like whether the lengthening will be different than the normal lengthening. Right, yeah. Okay, Premal, yes, what is your suggestion? Do you do something similar to the, in this case, or will you do something different?
Dhirendra, as I said, lengthening in fibrous dysplasia with such a large lesion is going to be a little difficult job. So I would really like to know from the patient if they're ready with that. If they're ready with that, then if they really want, it's a good idea. Otherwise, keeping the child under observation would be my first choice.
Okay, let's move further, because I know that on this point we can discuss a lot. So let's move further.
We performed Ilizarov leg lengthening at the level of the normal proximal tibia, unfortunately complicated by a regenerate fracture fixed with an interlocking intramedullary nail. 2 years after intramedullary nailing, fracture healing and uniform sclerotic aspect of the FD lesion are visible.
I think we stop at this point. So will you like to add anything to this, like what was done? Or I think the result appears to be very good. So what is your comment on this, Professor Hepty?
Well, I think it's a very good treatment. The only thing which I don't see is the ankle joint, because it had quite a severe virus before that, and now I don't see the axis of the ankle joint, but otherwise I think it's very good.
Okay, yes, Fargal, are you happy with the result, or?
Yeah, I think it's a good result. I don't think that the regenerative fracture is because it was fibrous dysplasia. That's just, I think, part of segmental lengthening, and I think it's a very nice job.
Good. So let's move further, because we have still more questions to be discussed in the second case.
Both polyostotic form and McCune-Albright syndrome account for about 20–30% of all FD cases. They usually have an early presentation. They rarely run asymptomatic. And their chronologic progression up to 90% of skeletal involvement, as assessed by bone scan, are the first appearing are the craniofacial lesions by 3 years of age. The second appearing lesion are the extremities lesion by 13 years of age, and the last appearing lesion affect the axial skeleton by 15 years of age. In McCune-Albright syndrome, endocrinopathies may become clinically evident even before skeletal lesions. Typical is precocious puberty in both female and male patients. PFD differential diagnosis must be mainly made from multiple non-ossifying fibromas, multiple enchondromatosis, and juvenile Paget's disease. In PFD McCune-Albright syndrome, skeletal involvement may be diffuse. Femur and tibia are affected in almost 80% of cases, and they may develop typical deformities. Skeletal deformities may progress and change their pattern during growth, mainly in femur, as you can see here. And risk factors are young age diagnosis, McCune-Albright syndrome, rapid spreading of fibrous dysplasia lesion from the cervicotrochanteric area to the diaphysis, shaft cortices thinning, calcar osteolysis, and cystic-like lesion in the intertrochanteric area with calcar erosion. And you can see here another case of typical progression. In a cohort of patients with polyostotic fibrous dysplasia, McCune-Albright syndrome, published by us, scoliosis was present in 33% of cases. In 21% of cases with scoliosis, spine was involved by FD lesions. Scoliosis was significantly more present in patients with pelvic involvement and pelvic obliquity. Fortunately, scoliosis was not evolutive in 77% of cases with short curves, but owing to the high prevalence of scoliosis, we believe that spine must be included in the clinical radiographic survey of PFD McCune-Albright syndrome patients. Medical management of fibrous dysplasia. Bisphosphonates have been the first drugs used in this disease. As you know, they bind to hydroxyapatite crystals by inducing osteoclast apoptosis. They are active on pain control by intravenous administration, but they are not effective by oral administration. They have no effect on limitation of FD lesions expansion, and they do not bind to the poorly mineralized FD matrix, as we have shown in this histologic study. Denosumab has been recently used in McCune-Albright syndrome treatment. Denosumab is a monoclonal antibody to RANKL that prevents activation of RANK receptors present on the surface of mononuclear preosteoclastic cells. It blocks FD lesions evolution and induces marked mineralization of FD matrix. However, when stopped, osteoclastic activity resumes with FD lesions recurrence and consequent life-threatening severe hypercalcemia. Experimental studies in mice with FD showed that an anti-mouse denosumab induces normal bone formation within FD lesions and prevents the formation of new FD lesions in young mice. An association of denosumab with zoledronic acid is suggested to prevent the dangerous increase of serum calcium level induced by denosumab discontinuation as well as FD recurrence. Studies on this combined treatment are in progress on FD mice. Burosumab is a monoclonal antibody to phosphaturic factor FGF23. It is effective in patients with X-linked hypophosphatemia caused by FGF23, as shown by Carpenter and co-workers. But clinical trials are in progress on McCune-Albright patients with FGF23 at NIH, USA. At present, McCune-Albright patients with phosphaturic factor are routinely treated by oral administration of calcitriol and phosphates with limited effects, at least in our experience. In severe cases, the first deformity that shows up after the child starts to walk is coxavara with Trendelenburg limp in unilateral and waddling gait in bilateral cases. And the family is worried. And this is our question case 2. This is a 3-year-old limping child with impending coxavara on the left, 6 months after the child started to walk. What to do? Observation, restriction of walking, brace, surgery.
Okay, so let's have an opinion on this. Let's start with Fergal. What do you think? How will you treat?
This is a polyostotic, so I want to know whether this is progressive or not. So on one X-ray, I haven't probably got enough information. I think options 2 and 3, I would discard because I think that they're probably more treating the surgeon than the patient. Observation, provided it's static and not deteriorating, but if it is deteriorating, then I'd be talking about a realignment osteotomy with a plate. Okay, the mechanics aren't great and it's difficult in a fibrous dysplasia lesion, but if it's progressing that quickly and that young, then it's going to only become more difficult. So it's a tough call, but I would be more aggressive in this because she's very young than if someone who was, say, 8 or 9 years old. And it will, for me, be down to the rate of progression documented by serial radiographs. How big the interval depends on how nervous you are.
Okay, Premal, what is your take on this?
I think if, as said by the Fergal, if the lesion is progressing on serial radiographs, it may be a good idea to correct the deformity and maintain it by some intramedullary rod with something going in the neck, like we do it in osteopathy with a growing rod with multiple K wires at this stage in the neck, and we may need to revise it again in longer follow-up.
Okay, yes, Thomas, what do you suggest for this case? Thomas. Okay, by the time he's with us, Professor Hepti, what do you suggest for this case? Of the 4 options, what is your preference?
Well, I agree with Fergal. I would observe it and look how progressive it is. And if it is progressive, I would do a stabilization, a correction and stabilization. I would not restrict walking and I would not put the brace. I don't think that they are effective and they are quite harmful actually for the child.
Okay, right. So let's see what was done.
Restriction of walking was not effective. The child is now 3-year-old and he walks with a marked waddle gait. Very often he refuses to walk. What to do now? Still observe the case, brace application, do surgery in this case, what kind of surgery?
Okay, so again, let's start with Professor Hepti. Now the situation has deteriorated, so definitely we need to intervene. So what will be your preference of our intervention?
Yes, certainly we should do an operation. This is biomechanically a very bad situation and will deteriorate even faster than until now. I think, as far as I can see, it's quite confined to the upper femur. So you can try with a standard surgery with an osteotomy and the plate. But maybe an intermedullary nail, a telescopic nail, as I will show it later, would also be an option. I must say we have never operated on a young child like this with the nail, with the intermedullary. So probably a plate would be okay.
Okay, so at 3 years, further, what will be your preference for implant?
I would use a blade plate or equivalent. What's going to cause this to succeed or fail is the quality of fixation you get. And if you're using an intermedullary device that you're sort of trying to squeeze into the indication, I just think that that's probably not sensible. I know mechanically on a drawing board it's better, but if you can get a blade plate with a conventional sort of Powell's type, or just a realignment osteotomy, although you haven't got much normal bone on the neck side of the growth plate, the best chance you've got is, I think, with a blade plate or similar. I think screws won't hold it. A blade plate will be rotationally stable as well, and I just have the advantage. And if the worry in a 2-year-old is damaging the growth plate, but that becomes slightly irrelevant if this all falls apart. So you're going to have to take a risk and go as close to the growth plate you can with as broad an implant as you can and correct it as best you can. And I would warn the parents that this is almost certainly not the only operation that they will have. It will deteriorate and it will require redoing. But as this child grows, the amount of normal bone in the neck by the growth plate is likely to increase. The growth plate bone addition should be reasonably normal, and the cystic area should move away from it. So if you can just temporize it with fixation for a couple of years and then do it again and then do it again, that's what I'm looking at. Okay. But at both sides, and it's big surgery, and there's a high risk of it failing.
Okay, Thomas, are you with us or still?
Yeah,
yes. Yeah.
Sorry, my connection was a little unstable. But as Mr. Hefty and Mr. Wansel said, we have not done on such a young child at 3 years, but this biomechanically doesn't look like a good position. So if we are forced, after medical management with the endocrinologist for the polyostotic, and we will probably use a valgus, the synthis valgus osteotomy plate works well in younger kids, good hold. Before we used to use a rush nail with tension band, but the hold is not so great. So if we are forced to correct the coxavera, we do it with a valgus osteotomy plate, the synthis valgus osteotomy plate.
Okay, Premal, would you like to add anything to the 3 opinion, or you agree with them?
I think in the long run, if there is another lesion in the bone, an intramedullary implant with growing capacity would be good. But as already said, the neck correction may not be very good with intramedullary implant compared to plate. So I think if you're using plate, then there is a risk of having a fracture at the end of it. And maybe that plate may need to be revised with a nail in longer run.
Okay, so how many revision do you expect, Fergal, in this case?
Realistically, at 2, and with the deterioration shown, I think you've got to be pessimistic when talking to the parents, and I'd say probably every couple of years. Now, if it's less than that, they're going to be very, very happy, and so will I. But looking at it, because the bone is poor, it's clearly quite aggressive. It's polyostotic. I'm quite pessimistic about it.
Okay, fine. So you will warn them that every 2 years you have to come for some surgical treatment.
I think that it sounds ridiculous, but I think if they can agree to that,
okay,
and I'm wrong, and it's fewer than that, then everyone's going to be happy.
Happy. Good. Right. So let's see what was done.
We performed bilateral valgus osteotomy stabilized with a 90 degrees synthis infant blade plate. There was a marked improvement of the child's gait. For how long do you think that correction will last? Do you expect complications?
Yes, Fargal, let's start with you.
Well, I think it's a lovely job, and I think the parents will be delighted. If it heals, it will be okay for now, but I would expect disease progression over the next couple of years, 3 years, something like that. Again, I think it's a very nice job now, but it's a temporary solution in this condition at this age.
Okay. Yes, Professor Hepty, I'm sure that this is very well done, but how will you respond to the parents about the future?
Well, I'm not quite so pessimistic. I give him 4 years.
I hope you're right.
Okay, and do you envisage any complication of this?
Well, the complication is the recurrence.
Recurrence. Okay, so nothing other than recurrence you anticipate. Let's see further what was done.
18 months later, there was a bilateral 10 degrees loss of the neck shaft angle correction and a stress fracture with a 25 degrees varus femoral deformity below the right plate. There was also a moderate limb recurrence. What to do now?
Okay, Premal, what you have anticipated, the same thing has happened over here. So how will you manage now? Will you take up this implant and will go for an intramedullary implant, or?
I think this is the best time to go for intramedullary implant and maybe have a screw in the neck, which is going to be short, but it may need to be revised so that, there is some strength in the neck as well, which may be miss a nail technique because we don't have interlocking nail for this age. But I think this is the child which is begging for intramedullary implant.
Okay, Thomas, how will you manage in your institute?
Yeah, so the problem is the diameter of the canal when it's a young child. An intramedullary device is best, but I think you can only get a rush rod through that canal. So we probably have to use a rush rod as an intramedullary device because none of those bigger nails, a Zickel or the bigger capsulomedullary nails won't go through this diameter. So we'll have to place a rush nail and then stabilize with a hip spica or something like that.
Okay. Yes, Professor Hepty, what will you do? How will you manage this complication?
Well, the varus of the shaft adds to the varus of the neck. So you really have to do something about this. And yes, I would correct that with an intramedullary nail, an E-sign or a Nancy nail or such a thing.
Okay. So I think all of us agree that some intramedullary implant has to be done. Okay, yeah.
We removed the right plate and we corrected the femoral deformity that was fixed with 2 K wires and a hip spica cast. But 14 months later, recurrence of coxavara and varus deformity below the left plate are evident. What to do now?
Okay, so will you manage with the same way or you will prefer to go for intramedullary implant? Fargal, what will be your take for this now?
Again, how much, what symptoms have we got? It will depend if they're completely asymptomatic. And again, there's not a rapid deterioration. You don't have to be quite as aggressive as on the other side. But I agree, the mechanical principles are the same. This is adding to the varus of the proximal neck and it would be better off corrected. It's difficult. You've done a very nice job correcting it with just K wires. That's clearly worked. But I'd prefer to remove the implant, I'm struggling because do I wait for it to break or do I do an osteotomy? And I would probably, if there is a progression and if they're starting to lose function, I would do a plate removal, osteotomy, and straighten it with an intramedullary device of some sort. What we use a fascia valve because we use it a lot in osteogenesis. The child's now about 4 years old, I think. So you could get a reasonably good fascia valve rod into that or equivalent. And that's probably what I would do aged, I think she's about 5 now, I think.
Yes, yeah.
But I'm doing it more to protect the proximal femur than because I'm particularly worried about the distal femur. One other point I'd like to say is this just a reaction of normal bone beneath a plate, or is the fibrous dysplasia more extensive than we anticipated on the first X-ray?
Okay, let's see what was done. Let's move further.
The left plate was also removed and the child followed up every 3 months. His condition remained stable up to 6.5 years of age, when further loss of the neck shaft angle and impending shepherd crook deformity became evident, together with marked limp. What treatment now? Brace, surgery? What kind of surgery?
Yes, so now from the beginning, we have come to at least 4 years further. So now what will be the management? Now will you go for intramedullary implant or the same type of blade plate? Yeah, Fargal.
Well, now as predicted, you've got what looks like a much better bone stock proximally by the neck. The child's bigger, and if you've got a reconstruction type nail that you can use in a 6.5-year-old child, then that would probably be my osteotomy at the diaphyseal deformity and some sort of intramedullary reconstruction nail. But she's still small, and you may have to have a custom type nail. But the best biomechanical answer to that would be intramedullary nail with a screw up the neck. A plate, it is certainly on the left, it does look like that there is fibrous dysplasia quite a way down that. And so you need a very long plate, and I'd be very uncomfortable about that. So short answer, an intramedullary nail with neck screws.
Yes, Thomas, will you do the same thing, and how will you manage in India?
So I think the limitation again is the intramedullary device, the diameter, like Mr. Monsell explained. So I don't know what the diameter is. If it's wide enough for a intramedullary device, that is the best. If not, what we do is to put in a rush nail and put in a tension band for the neck, and again correct the coxa with the tension band wire at the trochanter. Again, it'll recur, but we're waiting, we're biding time here.
Okay, right. Let's see what was done.
We performed one-stage correction of both coxa and shepherd's crook deformity on the left, and 8 months later on the right. Between the two intramedullary nailing, the boy manifested precocious puberty with a marked growth spurt. Correction was fixed with an adult humeral nail. The boy is now 8.5-year-old, and the left nail has become short with coxa recurrence on the same side.
So any comment about the future? Yeah, Professor Hepti.
Yes, well, the problem is that there is still coxa and of course this will progress. The boy is 8.5 years old. I cannot really assess how much growth is remaining. You say it's pubertas precox, but still, I think one time it will need more surgery.
Okay, let's move further because we are running short of time.
And now a brief question, case 3. Do you think that the new 130 degrees angulated Orthopaedics cannulated infant hip blade plate could guarantee a long-lasting correction in comparison to the 90 degrees Synthes hip blade plate in children with early coxa?
Yeah, so basically we want a short answer, yes or no. What do you think about this new implant? Are you optimistic or not about much optimistic? Yes, Professor Hepti.
Well, I think the key of everything is how much valgus you get. You have to get enough valgus. And yes, the 130 degrees angulated plate is certainly better if you have a good cortex, a lateral cortex. If not, you cannot really use a plate.
Okay. Yes, Fergal, are you happy with this implant or you are still happy with the 90-degree blade plate?
I'm happy with both implants, but it's the disease that determines what happens next. And I think I don't think it's going to make a fundamental difference. It gives you a slightly better option, but fundamentally it's the quality of the bone and the mechanics of the proximal femur.
Okay, so that's a very important point, that it's not the implant, but it's the quality of bone which is going to decide a lot of prognosis. Good, good.
According to our experience, the answer is no, as you can see in this radiograph, in which a 20 degrees loss of correction of the neck shaft angle occurred on the right 6 months later, when the left plate was replaced with an adult proximal humeral nail with a partial restoration of the primitive 130 degrees correction on the left. So, in conclusion, fibrous dysplasia of bone has a broad spectrum of severity, ranging from localized monostotic forms to diffuse polyostotic forms associated with endocrinopathies, as in McCune-Albright syndrome, that may further increase skeletal fragility. Differential diagnosis of monostotic forms from other skeletal tumor-like and tumoral conditions may be sometimes difficult. In those cases, a bone biopsy, more than an imaging working out, may help to make a correct and quick diagnosis after the first radiograph. Some diffuse monostotic forms have a difficult treatment and a poor long-term prognosis. McCune-Albright patients with FGF23 phosphaturic factor have the worst prognosis for both fracture prevalence and bone deformity progression. In many of those patients, even excellent surgical results may deteriorate in time and require an early revision surgery. In our experience, early surgery based on intramedullary nailing techniques offers long-term satisfactory results in the majority of PFD-MAS patients, although poor results should also be expected. In young children, intramedullary nailing must be repeated during growth, and families must know that the risk of surgical complications is high. Peripheral plates must be used only in particular cases because the risk of complications is very high. Curettage and bone grafting are only indicated in localized monostotic fibrous dysplasia. The development of mouse models with FD mutation is an important tool to elucidate the natural history of the disease and to design and test new therapeutic strategies. We believe that in the next future, thanks to this experimental FD mouse model and to a better understanding of the pathophysiology of the disease, new drugs will improve the quality of FD bone and will help surgery to provide a better long-term prognosis even in severe McCune-Albright syndrome cases. Thank you very much for your attention.
Yes, thank you very much, Professor. So now we move on to the Professor Hepty's new implant which he has devised, and we have a lot of hope about this new implant. At present, it's not available in India, but he has some recommendation how we can develop in our country. Yes, Professor, you can share your presentation.
Okay. So this is really an implant for Shepherd's crook deformity. And it's an implant, it's a retrograde nail. This is the main difference to this standard implants. I think Shepherd's crook deformity is one of the biggest surgical treatment challenges because it's a very severe deformity and the bone is extremely soft. And usually plates and standard gamma nails don't really help, or at least not for a long time. And the main reason why the gamma nail is a difficult implant for these cases is because you cannot insert it from the standard insertion from the trochanter in enough valgus. Because of the pelvic bone. Your pelvic bone here impedes your implantation from the right direction, which should be like this. And you can't come in like this because you have the pelvic bone. And this is why we developed this nail.
Sir, we are not able to see your presentation. So can you share your presentation?
Yes, but what is the problem? I have it on my screen. You don't see my screen?
No. So please go to the share screen.
Yes. Share screen.
Yes, and then you will see your presentation.
Where is share screen?
That's a green arrow on the bottom.
Oh, yes. Okay. And now? Is it now?
Yes, yeah, please.
You can see it?
Yes, yes, yes.
So, yes, this is the Shepherd's crook deformity, and which is a very difficult problem. Now I can't go on. Oh, yes. Yes, and this is the drawing how the pelvis impedes the right direction for your implant. And this is the principle of the nail. We first make the osteotomy, and then we make a maximal adduction of the shaft. And now we can come with a reamer from the osteotomy and go down to the knee. If we have a telescopic implant, so we go down until the knee, and this is a telescopic part which goes through the plate, and we put a screw into a little hole in that telescopic part and bring down the nail until the knee, and then we do we ream a hole in the neck in the preferred direction, which is much more in valgus than you usually have, and then we can push the nail up in that hole, which is here. And for this purpose, the nail has rings around the nail. So with a small window in the shaft and the hammer, you can push the nail up into that hole you have reamed before. And this is then the situation at the end. You insert 2 femoral neck screws because the nail, of course, is like a gamma nail. It has 2 holes for 2 neck screws. Now, a few examples. This is a patient, 14 years old, who had this kind of varus deformity. He had a fracture and had a plate. And this is the treatment we made 1 year postoperatively. And you can see the telescopic part. This, of course, is only necessary if you have enough growth remaining. If you don't have enough growth, then this is not necessary. This is an older patient, already grown up, with a very severe deformity on the right side. And we inserted our retrograde nail on the right side. On the left side, we used the normal gamma nail. And here another case, again, a very severe deformity. It's a bit difficult to see. And our retrograde nail with the improved shaft angle. This again, an example. And here, even more severe shepherd crook. That is the planning. The planning is very important, and it's also very important to know the length of the nail, because you have to bring it down before you push it up. And the width usually is not the problem, because these shafts are very wide. And this is the correction. You can see we can do a very massive correction with this method. Here again, that already had a gamma nail before, but still had a very severe shepherd crook deformity, and we corrected it with the retrograde nail. Or here, even more severe. They always have a severe retroversion when they have such a varus. So you have to correct the retroversion also. And this is the result of it. Again, the telescopic kind, because of the open physis in an 11-year-old. Until now, we have 22 patients with 34 limbs. Majority had fibrous dysplasia. 7 had the McCune-Allred syndrome. Age at time of the operation, in average, quite young, 7.8 years. The youngest was not quite 6-year-old. You cannot do it in younger patients because the shaft is too thin for a telescopic nail. The follow-up time is more than 4 years now, and between 7 months and 132 ones. Of course, we had complications. 1 recurrence of the varus, 1 breakage of the nail, but that was after 8 years. And the most severe complication was a penetration of the screw into the acetabulum. This patient was not able to walk anymore. And proximal screw migration, we had to remove the screw, and rotational deformity residual, that was also a problem in 2 patients. But the walking ability improved very much. You see, preoperatively, only 3 patients were able to walk without aid, and postoperatively 17 of the 22. Only 1 had to use crutches because of the femur. 3 had crutches because of other reasons, mainly the ankle joint was the problem they had. And preoperatively, 9 were completely unable to walk, and postoperatively only 1. That was the one with the screw in the acetabulum. Pain also was improved quite significantly. Before the operation, 15 with severe pain, afterwards only 1, the one with the screw in the acetabulum, and moderate 6 before and 2 afterwards, and no pain in 19 of the 22 at follow-up. We have published this method 3 years ago in the Journal of Children's Orthopaedics. You can read everything about it. And this is how the nail is looking. It's custom made. We make every nail on exactly for the specific patient. But if you don't use a telescopic nail, you can use a standard gamma nail and can produce this nail yourself. You take a standard straight gamma nail, in the correct length and width, or especially the width, then you have to plan, of course, very carefully. And your hardware department can add the rings. That is not a difficult thing. So if you have a good hardware department, you can add the rings. And if you don't have the exact length, your hardware department can cut the end of the nail. You take a bit a longer nail and cut the end, and then you have a custom-made nail also. Of course, the telescopic variant is more difficult to make. And if you have questions, you can send me an email. The address is on the publication. If the material is weak and brittle, we should minimize the bending moment. That's the essential. Thank you very much.
Yes. So I should like to ask how difficult it is to remove this implant.
It's very difficult to use it. It's a difficult operation.
No, difficult to insert, but to take out the implant, how difficult it is.
Oh, yes. Well, it's not meant to be taken out.
Okay.
But of course, you have two options. You can make an osteotomy, and usually if you have to take it out, then it's because you have a recurrence of your problem. We didn't have to do that until now. But the other option is you take it out from the knee. But this, again, is not a very good option.
Okay, then there is a question like, how do you lock it proximally? Do you use the jig for the proximal locking or the proximal locking?
Yes, that is also quite difficult. We have a very good situation because we have a 3D CT scan in the operation room. In the beginning, I used the image intensifier and went through from laterally, but with this thin bone, you don't see very much, and this is quite difficult. But of course, you can also dissect a bit the anterior part of your femoral neck and get an idea of the direction. But it's difficult, yes.
Yes, there is another concern about the radiation dose. What is the radiation dose of this procedure?
Well,
have you calculated that, or?
Yes, the main problem is, of course, if you go laterally through the femoral shaft, this always is a certain radiation to the gonads. Yes, of course, you have got a radiation dose.
Okay. Yes, further, what do you think
with our CT scan now, it's not a problem, radiation.
Okay. Further, what do you think? Is it possible to have this type of implant in your hospital?
Yeah, I mean, it is with negotiation. It is. I presume it's CE marked. Well, we're not part of EU anymore. It's CE marked, and if we'd have to, there's paperwork that goes with it. But if we had an indication, a specific patient indication, we could use that. I like it a lot. It's so sensible. It solves so many of the problems that if you approach this with the stuff you get out of conventional boxes, you run into trouble. And this has been thought through very carefully to solve them. So I think it's got a really, really big place for these very difficult cases.
Okay. Yes, Professor Ippolito, what do you think about this implant? Yeah, you need to unmute yourself. Yeah, please unmute yourself. Okay, let me see whether I can do it or not.
Fritz?
Yeah?
Yeah, please.
How much does the nail cost? The cost of the nail?
Well, I think it's about, we paid around 3,000 euros, 2,500 euros.
That's actually
Okay.
That's actually quite competitive from European prices. Some of the standard implants are very similar to that.
Okay. And definitely this is very difficult for us to have in India, but for a difficult situation, this is probably we have a hope that it will reduce our some of the problems related to the weak bone. So now we will have the third part of our session, and Fergal is going to tell us about the protocol which they have designed and which they have published in the journal. So he's going to give us some highlight about that presentation.
Can I screen share, Darren?
Yeah, please, please.
Yeah. Do you want the short or the long? Short would probably be better, or do you want the long one? 5 minutes or 10 minutes?
5 minutes, 5 minutes.
Okay, we'll do the short one then. There you go. This is really just a very quick run through, just for your information. We tried to define best management guidelines using a consensus approach. And this basically, the aim really was to develop a standard of care for guidelines of the management of fibrous dysplasia and McCune-Albright syndrome, because by very nature of the conversation during this talk, although we have similar ideas, there's a lot of the issues that are associated with this condition that don't have very clear defined protocols. I'm going to concentrate on the orthopedic side, but this dealt with all aspects, including endocrinology, hematology, imaging, etc. But this is just a very, very brief run through of what we defined for orthopedics. And the idea was just so we could improve outcomes for these patients. And there's nothing that you haven't already heard, but if you're interested, I'll give you the source for the article so you can read it in some detail. And so we used an approach in which we had a consensus meeting, identified key questions, did a literature review to see what had previously been published, and we used a systematic review of all available literature. We put that together and made a consensus draft, which we circulated it globally, and then we had a 2-year writing group review dealing with anything that on the Delphi approach had over a 70% consensus, and we published this last year. And the general diagnostics, radiological features, histological and genetics, and then the skeletal features, we all dealt with separately. And for the skeleton, we divide it into the spine and the limbs, but also included craniofacial and teeth as part of the skeletal system. And the extraskeletal, and as we've described, each of these had its own particular management issues that we got a consensus-based protocol about how to do it. And it basically involved general patient information, a lot of patient input to this, just about lifestyle advice, about improving bone health, about maintaining mobility, about how to manage bone pain, particularly with pharmacological intervention, and management of all separate parts of it. I'm skating through this because I don't want to overrun for you. And the skeletal manifestations, we looked at the symptoms, examination, imaging, and then what the bone-related lab testing was relevant to the management of these patients. And so we produced a skeletal map, so any patient with fibrous dysplasia, particularly polyostotic or McCune-Albright, a skeletal map of joint pain, of bone and joint deformity, fracture history, all previous management, so that each patient has got their own record of their disease, because they will have frequent interaction with medical professionals. It's just very straightforward for them to have it all available in front of them. Imaging, we thought, because all of the skeletal burden is detectable by 15 years and all of the clinically significant lesions are detectable age 5, we thought screening of patient over 5 years by whole body imaging, MRI scan if available, or low dose 2 or 3D radiography, including EOS if you have it, or with bone scintigraphy, so that at the age of 5, you can identify all lesions that will become clinically significant. And when you identify them, then you just do conventional whole bone radiographs to see the extent of the lesion. And if there are any specific issues, including nerve entrapment, then fine cut CT scan. And the lab testing, again, I'm just going to run through it. There's nothing particularly unusual about it. It's just a standard bone health profile. In a patient with McCune-Albright with the endocrinopathies, obviously there is a much more complicated a biochemical assessment that's needed, but I'm just going to concentrate on the bone because of time pressures. And the orthopedic recommendations, which we've actually covered in the previous talks, is that curettage with bone grafting, whether it's autogenic or allogenic, really is unsuccessful, and it's not likely to improve outcome, and it comes with its own morbidity and therefore is not recommended. Intramedullary fixation involving the involved bone is the recommended way of approaching this. And in the examples that we've seen in the previous two talks, unless there are special circumstances which make it technically difficult to insert an intramedullary rod. And the examples that we've seen is in the very young child, or in patients with very poor bone stock, conventional or custom-made titanium implants. There's some evidence in the literature, and although it's not clear why, that titanium in fibrous dysplasia produces better results than steel. And it's probably something to do with the local mechanical environment, but it does look like it's a real observation rather than just an aberration. And then finally, allogenic strut grafting, which has had its exponents, is not recommended, particularly if there is a fracture. It will not give you proper skeletal integrity. It's probably useful in small segment lesions prior to fracture, but once you progress to incomplete or complete fractures, it's something that the literature and the consensus group would not recommend. And we produce algorithms for a number of things, including pain management, management of craniofacial symptoms. And this is one from the orthopedics for the femur. And it's a very simple go, no-go diagram about management of femoral deformity. And for the cases we've seen, if you see my arrow, for the one we saw in the infants, is it possible to form a valgus deformity? If it is possible, a customized plate. If it's not possible, and then if there's no deformity, you go down a different route. It's just, it was a simple guide to treatment, not for orthopedic experts, but for medical professionals and patients who have this disease, to try and explain the thought process behind the orthopedic management. And I think this is just basically a single page diagram which explains the discussions that we've had previously with the cases. That is the document. It's a large document. It's very cumbersome. It is for the enthusiast. And if you're interested, that's the where you can find it. I think that's all. I've got a longer talk, but I think time prevents me from doing that. I promised during that I'd give him 5 minutes at the end for him to do the tidy up, and we've got 6 minutes, so you owe me a minute.
Yes, thank you very much, Fergal, for finishing well in time. I'm really happy that we have a wonderful interaction today. And before I end, I just would like to tell about your understanding about the future. In next 2 decades, how do you see the management of fibrous dysplasia will change? So let's start with Professor Ippolito first. What do you think? At the end of your talk, you talk about that mouse model, which is going to help us a lot. So what else do you think is going to help us a lot?
So I think that, you know, the future may be in medical treatment, of course, you know. Actually, the possibility of combining, you know, the denosumab with zoledronic acid may be a first good answer to the problem, you know. Just because, as you know, if we stop suddenly denosumab, we can produce, life-threatening, very high hypercalcemia. But if we combine, zoledronic acid before you stop denosumab, you can, readjust calcium metabolism. And this is, the first step, I think, toward, good possibility of medical treatment, mainly in McCune-Albright syndrome. The other point is the new antagonist of FGF23 that is, already been used in X-linked hypophosphatemia with good success. And as we saw before, the most complicated and difficult to treat cases are McCune-Albright cases with very high FGF circulating FGF23. So that's the future, I think.
Okay. Yes, Professor Hetty, what do you think? Like the medical management is going to change the outlook of this condition?
Well, I hope so, yes. I hope that we can have improvements, especially in McCune-Albright syndrome. Maybe the geneticists can also do something. Genetic treatment, maybe prenatal diagnosis is also something which can be improved. I also, like Ernesto, I see mainly improvement in that direction and not so much in the surgical treatment.
Okay, before I come to the Fergal, Premal, what do you think about this? In India, if we really want to change the management of this condition, what is your ideas?
I think thing is that to explain the parents that we are just treating the part of the disease and not the disease we have treatment for is something which we need to inculcate in parents, which is very difficult in the socio-economical strata and education level we have in our patients. But as we have seen that Dr. Ippolito showed, every 6 months a surgery was done. I don't think many patients in India would follow up with a single surgery. So till we have some basic research about this treatment, like we have some availability of genetic treatment for the condition, or if we have some better medications available, it's going to be enigma for all of us, at least in our country.
Yes, I fully agree with you. Thomas, what do you think about this?
Yeah, I think the future is bright, as Professor Ippolito said, with advances in pharmacological therapy, mouse model, mutational testing. But from an orthopedician's point of view, that what Professor Hefty showed about that customized implant, whether we can develop some good implants with 3D printing in the future, computer printing, development of better implants and metallurgy like titanium, as Fergal mentioned, and hopefully some better tool for the age group between 4 and 10, which is really the problem area because the canal is narrow. Above 10 and the adolescents, I think we have good implants, but that age group, luckily in India, we don't see what Professor Ippolito sees in Italy. We've never seen children less than 5 with that much of coxa-vara. So in a sense, we are lucky, I think. But I think future of 3D printing, mutational analysis, better pharmacological therapies will be the future.
Yes, and Fergal, what do you think? Like you have searched the literature a lot, and what is your ideas about future?
Well, I think the problem we've got is the bone, and we've got tools, we've got skills, we've got implants, but the main problem is the quality of the bone in this disease. Therefore, it's pharmacology and genetic manipulation, I think, is got to be the only way forward. And I agree, and certainly in some of the more severe, like the MAS ones, with some of the pharmacology now, that is making some improvement. The problem is the genetic defect that causes fibrous dysplasia is such a downstream, pathway problem. And it's how do you turn the how do you replace the osteoblasts that are affected in this condition? But now we know what causes it. We've got a GNAS mutation, which has been identified in pretty much all fibrous dysplasia. That tells us why, but it hasn't yet allowed us to say, and therefore we can do this to make the osteoblasts work again. And so I think that that's where the future has to be. And I'm very optimistic that that will be possible, but not by someone like me.
Okay, so
no, I'm waiting for the clever doctors to turn the osteoblasts on again for me.
Right. So like we saw a lot of progress in the management of this difficult condition. And we all expect that with more research in the genetics, in the medical management, probably the outcome of this condition will improve. And with this message of hope and optimism, I would like to thank all of our expert panelists to come over here and share their opinion with us. Thank you very much and have a wonderful time. Thank you.
Thank you.
Thank you. Yeah. Bye-bye.
Bye-bye.
Yeah. Ashok,